In this lesson, we'll learn about medical and research ethics. Before we get started into more detail about research and medical ethics, we have to talk about science and the debate about objectivity and subjectivity. Take some time to really think about what these two terms mean. Often we use the word objectivity to refer to things like truth or science as the only way of knowing. I would like us to really challenge that idea in our course to think about subjectivity. Subjectivity is often thought of as bias or not considering all the facts. This is not the case. What subjectivity is taking into account is individuals or groups' lived experiences and perspectives that gives a sense of truth, that shares and shapes their realities. In addition, objectivity is really pertinent and important for hard sciences like biology and physics. Subjectivity refers to more social sciences and how human beings conduct their lives. We have to consider ethics. This course is all about ethics. In terms of doing research, either medical or for science, we must respect subjects' rights to safety, privacy, confidentiality, and informed consent. Right to safety simply means do no harm. Right to privacy refers to the research subjects having the right to decide whether their attitudes and behaviors may be revealed to the public, and if so, in what way. Right to confidentiality refers to the fact that researchers cannot use data in any way that allows them to be traced to a particular subject. So keeping things very separate. We don't want to identify the respondent. Next, right to informed consent. Subjects must be told how the information they supply will be used. They must also be allowed to judge the degree of personal risk involved in answering questions. And when doing research, you must let the respondent know that they have the right to not answer any question that they're not comfortable answering, and also that they have the right to withdraw from the project at any time without penalty. So deception. Is deception okay when doing research? Well, it really depends on your research purpose and also, again, back into what we just talked about the last slide here, rights for the respondent. If those things are protected for the most part, yes, deception is okay. But at the end of each research project or medical practice, you must let the participant or respondent know what was the purpose of this project. I would like for you now to watch the Milgram experiment. I want you to take note what you think the purpose of this particular project is, why deception was used, and if you think this is an ethical research project. And if it is, tell me why, and if it's not, think about that as well. In today's time, Milgram's experiment would not be something that we would do today. It would not meet IRB requirements, and IRB is Institutional Review Board. There's too many dangers that could be possible when doing the Milgram experiment. So we're going to talk about using an intersectional approach, which is part of feminist methodology. Feminist methodology treats women's experience as legitimate, empirical, and theoretical resources. So going back to the idea of objectivity and subjectivity, we're taking the idea that someone's subject position, their identities, are important to understanding their ideas of truth and how they make sense of the world. This type of data is important for social scientists. Feminist methodologies promote social science that may bring about policy change to help women and other marginalized groups. So again, we're not just doing research for research's sake. Those using a feminist methodology want to improve circumstances and society for all people. Feminist methodology takes on a conscious role of the researcher as well as the subjects being studied. So we have to do a lot of reflection and self-examination about why we're doing this research, what's our intentions, and what power dynamics do we have between ourselves and those being researched. Okay. Another note that is important is that feminist methodology is not meant to exclude men's perspectives. Rather, it is meant to add to men's perspectives. Much previous research has neglected the input of certain individuals who are not taken as seriously as others. So, feminist methodology tries to account for some of those oversights. Okay. So as I stated before, when we're doing social research, we must go through IRB, and that again is Institutional Review Board. Researchers must meet codified standards, which are set by professional associations, academic institutions, or research centers when conducting studies. One of your very first activity journals that you can do is to take the IRB training, okay? For this particular assignment, I want you to go through the training, take a picture, a screenshot, or send me the PDF of the certificate you get at the end of your lessons. With this, you'll need to apply theory and explain what you've learned now about why we care about research ethics. Next point here is that researchers must guard against causing physical, emotional, or psychological harm to their subjects. Again, the point from the first part about protecting participants' rights. Simply do no harm. Okay? You may have heard about historical research like Watson's Little Albert study, Zimbardo's prison study, or Milgram's shock study. These kinds of studies might tell us something about social life, but possibly at too great a cost. That's why it's so important to think about ethics. As a result, or the professionalization and standardization of the field, we now tend to avoid projects with these kinds of risks, or else we approach them with great caution so as to protect our research participants. That's the number one goal, is protect your participants. Next, informed consent and voluntary participation are guidelines researchers use to ensure subjects know they are participating in a study and have voluntarily chosen to participate. If you have ever participated in a research study, it is probable that at the onset of the research, you were informed that you are participating in the study. They will disclose that to you. It is also probable that after your participation, you were debriefed. This is all part of the process of informed consent, making sure the respondent or participant has all the information to give consent. Next, the medical profession. Doctors have a great amount of social power, political power, and prestige for a variety of reasons. Think about your perspective of physicians. What kinds of notions come to your mind? Do you automatically give them respect because they wear a white lab coat? Do you speak to them differently than you would to an average person? Okay, we tend to really give prestige to physicians because they offer a universally valued product, health and longevity. Doctors have a great amount of social power, political power, and prestige for a variety of reasons. They offer a universally valued product, health and longevity. There is a limited number of doctors due to extensive education and training, as well as a strict regulation of the profession. So since they risk so much and have so much education, we value that. And so we give them more honor and respect. It takes about 20 years or more, plus a medical residency, before a person can become a practicing physician. So again, because all this time and risk and sacrifice, we give them more prestige. In addition, doctors are concerned about their standing among peers. People trust doctors with very personal information, and so they want respect among each other, but we want to feel like we can trust our physicians. When we go see doctors, we want personalized, individualized treatment. We make sure that our time and money are being valued. Okay? However, doctors know that. And so because of this, doctors use specific props and scripts to assert their power. They're putting on a presentation that we have to be willing to accept. This hasn't always been the case. Doctors have not always been highly valued in society, but since the 18th century, their power and prestige have steadily grown as through advances in technology and knowledge. They have become much better at treating illnesses and injury. Doctors have banded together as professionals and developed licensing systems. In addition, doctors assume a dominant role in the relationship with hospitals because they were the ones bringing in new patients. There is now more external regulation of the medical profession, and there has been a significant increase in the use of alternative medications such as biofeedback, acupuncture, chiropractic work, and herbal medicine. So we're expanding the idea of medical care. So let's think about what it means to be sick. The idea of being sick, the definition of being sick is socially constructed. It can vary from time to time and from place to place. Tal Parsons developed the concept of the sick role, which assigns a sick person rights and obligations. And so we expect them to behave in certain ways. And we say certain things are excusable because a person is sick and playing or putting on that role. This idea of sick role is a very individualistic concept, which does not take into account how social conditions can affect a person's health. Let's take, for instance, if you're a person who's working class and struggling from paycheck to paycheck, and you have to make a choice on whether to take your son or daughter to the hospital. You will consider various things like, is this condition serious enough to see a doctor? Do I have money to go see a doctor? Will I be able to take off work to take my child to see a doctor? Again, these are social conditions that really affect a person's health. In addition to the accessibility of seeing a doctor, that may put a lot of emotional and mental strain on the person considering whether they should seek medical care or not. And stress is a high indicator or a factor contributing to a person getting ill. So back to the sick role. People occupying the sick role are not required to perform normal social roles and are not held accountable for their own condition. However, they are expected to try to get well and seek competent doctors to help. So when we see people not looking for medical care, not doing what we expect of them, we then blame them for being sick or think that their sickness is not real. What does it mean to be sick? And again, this varies from culture to culture and time to time. Like many other seemingly universal or stable concepts, illness is a social construct. We develop its meaning as a society. What it means to be sick or healthy has changed throughout history and also differs from one place to another. Okay, so right now there's a lot of attention and which is needed on mental health. In our country, we use the DSM to diagnose various conditions. One condition called multiple personality disorder and also schizophrenia are seen differently in other cultures. In other cultures, those who can see or hear things that others can't are seen to have spiritual powers that are praised. So again, this is a social construct. So let's talk about how we go about getting care and the healthcare system itself. So think about this. Is healthcare a right or a privilege? Unlike many other industrialized nations, the United States does not offer universal healthcare. We have four main types of healthcare in our country. We have fee-for-service, health maintenance organizations or HMOs, Medicare, and Medicaid. We value our healthcare system in our country a lot, and it is due to a variety of factors. One of the reasons is that we have great technology. Technological advances in medicine have now allowed us to detect diseases via genetic anomalies in the fetus, which raises difficult ethical questions and has major social implications. For instance, some parents may choose to um, abort the pregnancy if they think the child has a propensity or is likely to have a very troublesome and hard to manage genetic condition. Also, we're able to use technological advances to have multiple births on the other side of the spectrum. And this is due to assisted reproductive technologies and also successful premature births, which present further medical and ethical dilemmas. So with this case, we can use in vitro fertilization to fertilize multiple eggs, and we may have multiple births, or we may be able to really provide more security so that the premature baby have more time to develop due to technology. So here's a question for you. What are the benefits or advances in medicine? Are there any drawbacks to all our technology? Does everyone benefit equally from these advances? And are there any controversial issues that can arise with improvements in medical technology? So again, there's a lot of pros. I want you to think about some of those cons. There are some tremendous discrepancies in healthcare. Healthcare or quality healthcare is not accessible to every person. There are numerous healthcare discrepancies between races in the United States, with whites having the best outcomes overall. The starkest differences can be found between whites and blacks. Okay? This is true even of the lifespan in general, which is typically longer for whites than blacks or other minorities. White men on average live to be about 83 years old. Black men live to be about 71 years old. White women live on average to be 79 years old, whereas black women live to be 78 years old. One of the films that I would like you to watch for this particular module is Inequality Making Us Sick? And this takes into account the intersection of race and class. While some of the discrepancies in healthcare are due to differences in socioeconomic status, there are still significant differences between whites and blacks with the same income and educational level, which implies that racism and racialized stress plays a role in people's overall health. And this is really pertinent in the movie that you'll watch. Many middle and upper class African Americans also have high rates of hypertension or high blood pressure, which is known to be linked to stress. Also, middle and upper class blacks may face discrimination in cases where they're perceived as token minorities in the workplace. This is a vicious cycle. African Americans are more likely to be victims of both overt and subtle forms of prejudice. Although specific acts such as violent attacks clearly affect someone's health, so does the gradual accumulation of more minor injustices, which can lead to stress and high blood pressure, not to mention racism's psychological impacts. Some other issues concerning discrepancy and health is that we have a lack of minority physicians. And so let's think about why that even matters. Well, we tend to feel more comfortable with doctors who maybe have similar characteristics as you. They may understand your culture more, so when you're coming and presenting a certain complaint with your health, they'll understand a fuller picture of what that really looks like. In addition, the location matters. So if we're talking about urban areas or rural areas, there's just fewer doctors available for the whole population. Next, placement after graduation. Most white medical students, once they graduate, do not seek to go to minority populations as their first choice. We do see that more often with minority physicians. And back to my point of cultural familiarity, this goes with the idea of bedside manner. You want a doctor to really understand you, because not only is your physical health being checked, but this improves mental health. And when you feel like you're seen as a whole person, and the doctor is addressing your issues holistically, you're more likely to have improved health. Okay? And again, with culture, by having similar culture, there's better doctor to patient communication. You understand one another. So not all mortality differences have to do with healthcare. Some examples include dangerous jobs. Racial minorities are more likely to be in blue-collar and high-risk jobs than more white-collar or behind-the-desk jobs. Also, we see issues with environmental racism, and this occurs when environmental racism occurs when we have dumping grounds or nuclear power plants or other kinds of environmentally dangerous products and toxins are in poor communities of color. We see this with farm workers' exposures to pesticides. We see this with black communities located near industrial facilities that release pollutants in the air and water. Also, blacks and Latinos are more likely than other groups to live in older housing with lead-based paint, and Native American reservations are dumping grounds for nuclear waste. Other issues include poor nutrition and inadequate shelter associated with poverty. And because of this, people of color suffer stress-related diseases such as ulcers and hypertension. With this stress is induced by racism as well. High blood pressure occurs when confronted with racism, and especially when those who experience racist encounters do not fight back. More encounters with discrimination is related to medically verified health problems, and again, you'll see that is inequality making us sick. Selection theory says that there's a connection between low income and poor health. However, there's also mediating factors. For instance, other factors like genetics may affect both socioeconomic status and health. So for instance, if a person has poor health or a chronic condition, they may not be able to work, which again affects their ability to make money, to get out of their situation and to improve their health by seeking medical care. Drift theory, the drift theory explanation states that there is a connection between income and health. If you have poor health, you may be less likely to find gainful employment. So for this particular theory, poor health causes a poor social position. Social determinants theory states that social status can determine a person's health. So you are born into a particular position, social position, class, race, gender that's high in our society, you're more likely to not have to experience so much stress and have more resources available to you to protect your health. In addition, feelings of inadequacy, low worth, and stigma cause people stress and wear down their bodies. If you have taken out tens of thousands of dollars in loans and worked 2 jobs to get through college while your roommate is independently wealthy, the persistent pressure that inequality could affect your health directly by making you feel stressed, depressed, or angry, or indirectly by causing poor health choices such as smoking, using drugs, failing to exercise, and eating badly. So we see here there's all these different moderating effects that can cause someone to have poor health outcomes. What we see in terms of just populations and their health, married people tend to live longer. It is not clear whether marriage benefits a person's health or if a healthy person tends to get married. So we can take either side of this and make guesses. In addition, women live longer than men. This can be attributed to the types of illnesses each sex is more susceptible to, as well as how willing each sex is to seek medical care. Men tend to not seek out medical care as frequently as women. So now let's talk about mental health. The Diagnostic and Statistical Manual of the Mental Disorders, or DSM, provides a standard categorization of mental disorders and their definitions. Changes in this manual, particularly from its second to third editions, have strongly influenced how mental illness is understood and treated. Again, this here shows you again how mental health is socially constructed. If there was just one objective way of looking and identifying mental disorders, we would not have so many different editions of this manual. It'll just be one particular condition with these symptoms, and that's it. There has been a significant increase in the use of pharmaceuticals to treat mental illness. Some negative aspects of this change include devaluation of the benefits of talk therapy, overprescribing or misprescribing of pharmaceuticals, stigma attached to taking medication for mental illness, increasing power of pharmaceutical companies which have benefited from the growth of diagnostic approach. So again, in what way is pharmaceuticals for mental health connected to other industries or different institutions in our society? Many psychiatrists consider the use of pharmaceuticals as simply one tool in the toolbox of ways to treat an individual. But as the medical profession becomes more like a consumer model, and as the pharmaceutical companies market their products directly to consumers through advertisements, it becomes more difficult for the medical profession to convince patients that using medicines alone might not be in their best interest. So think about how these drugs are being advertised. And will this lead to better treatment for mental health or not? Why do you think this change is occurring? What kinds of benefits or costs come from the current use of pharmaceuticals? Okay, so let's have this discussion together. Do you think the United States should adopt a universal healthcare system? Why or why not? What are some pros or cons to this? We'll post this on the discussion board. Another question to think about is your race and your socioeconomic status. How does that impact your health? Okay, how do these two particular identities affect you in that you feel stress? Okay, do you have particular diseases that run in your family because of the intersection of your race and class? What we see in terms of healthcare and class, SES is socioeconomic status, is that middle class people are likely to have a private, personal, or family physician. This is so important because these doctors tend to have a long record and history of your medical life together. They know you personally and are more able to use their time wisely and give you better treatment. The poor, on the other hand, receive their treatment from emergency rooms, hospital clinics, public hospitals, and Medicaid mills. And with this comes a host of problems. You may not be given a proper amount of time to see your doctor. They don't have the history of your conditions and the various diagnoses and treatments you've gone through. And in the case of Medicaid mills, giving you treatments that are unnecessary so that they can rack up a higher bill. So again, these class differences lead to different treatment for patients. The Medicaid program is a federally funded program administered by the states that provide medical care to the poor, and the coverage varies from state to state. Please watch the video in detail about this. Medicaid program, or the use of Medicaid, is limited mostly to the poorest of the poor. If you make $1 over the federal poverty line, you will not be able to have the benefits of this program. Because of this, the Medicaid excludes many households with incomes below the official poverty level. What we see today is that 13.2% of the population is covered by Medicaid. Again, think about class. There are some problems that come with the Medicaid program. Many doctors will not accept new patients covered by Medicaid. Medicaid pays at a lower rate than private insurance, and doctors cannot bill patients for the difference. Also a problem is Medicaid mills. This is when doctors are treating large numbers of patients in an assembly line fashion. With this, they give as many treatments as possible to the patients, and sometimes these treatments are not needed. And this is fraud. So what are some specific problems that you see in our healthcare system? How are certain communities affected by the healthcare system as it is? And think again about intersectionality, the differences between white middle class families versus working class white families and other groups. What are some benefits to having the current medical care systems we have, and what are the costs? What solutions can you think of that would provide accessibility to quality health care for most Americans?